Okay, hello everyone, welcome and thank you for being here today. Again, my name is Madeline Chow. I'll be the presenter for this DNP project. I would like to take this moment to thank CareMore for sponsoring this project and Duke University. The itinerary for today's DNP project will be implementing and evaluating the use of PAINAD on patients in the Medicare Advantage program. So at about 11:40, I'll step out for about a few minutes so that the faculty can have a discussion about the project. And then once I return, I'll answer questions in the last 15 minutes. So before I start, I would like to request everyone in the audience, if you have any questions, write them down and save them until the end of the presentation. I do have the room to save open till 1 o'clock this afternoon Pacific time. So if you have any further questions after 12 p.m., I'll be happy to stay here to answer all your questions. Any questions from anyone? Okay, I'll begin. First of all, I would like to introduce my committee members to you. Dr. Mary Champagne is my advisor, faculty advisor, and chair of my DNP project. Dr. Champagne is a professor of Duke University School of Nursing. Dr. Barbara Turner, she's the chair of the DNP program in Duke University School of Nursing. Dr. Christina Hendricks, she's a professor in Duke University School of Nursing. And Dr. George Fields is a Chief Medical Officer in CareMore Essentials. Again, welcome and thank you for being here. So my project implementing and evaluating the use of PAINAD on patients in the Medicare Advantage program. This Medicare Advantage organization in Southern California has a house call program in which nurse practitioners provide primary care and palliative care to members of this program. The majority of these members have the diagnosis of dementia. The concern is that these patients has communicative difficulties with self-report of pain. So the house call programs for this organization is focused on palliative care with people have end-stage diseases, and the organization is interested in improving the quality of care and quality of life for these patients with the diagnosis of dementia. Patients with dementia often experience pain. However, patients with cognitive impairment may have difficulty communicating or reporting their pain symptoms. As a result of communicative difficulties in patients with dementia, pain may become undetected or untreated or even unrecognized. Untreated pain can cause adverse events such as depression, sleep disturbance, poor appetite, weight loss, increased agitation, increased disability, and reduced quality of life. Therefore, a valid behavioral pain assessment tool is warranted to help these nurse practitioners to detect and identify pain in patients with dementia who have decreased capacity to communicate, and thus pain can be treated promptly and appropriately. This organization is interested in improving the quality of life and quality of care in these patients with dementia. Specifically, the organization is interested in improving the assessment and pain treatment in this patient population. Currently, this organization is using 3 different types of pain assessment tools, which includes numeric pain intensity scale, visual analog scale, and von Baker-Faces pain rating scale. The organization is supporting the idea of using a single pain assessment tool for persons with dementia. Ultimately, the organization is interested in implementing a pilot project, PAINAD tool, as the pain assessment tool for patients with dementia. In the search of literature review, I used the keywords which included pain and dementia, dementia in older adults, and pain in dementia in older adults aged 65 and over. Inclusion criteria for this research literature included older adults, dementia, cognitive impairment, and communication difficulties. The exclusion criteria used were non-English journal children and critically ill and sedated hospitalized patients. Out of 26 citations that I got, only 7 of these publications met the inclusion and exclusion criteria which will be used to address the clinical question. Evidence suggests that PAINAD, a behavioral pain assessment tool used for patients with dementia, has strong reliability and validity and is user-friendly. PAINAD can be learned easily. It takes about 5 minutes of training to learn to use it. Studies indicated that PAINAD is highly correlated with pain behaviors. Internal consistency was 0.7. The inter-rater reliability range was 0.82 to 0.97. These findings support the validity and reliability of PAINAD in detecting pain in older adults with dementia, cognitive impairment, and communication difficulties. Goals of this pilot project: implement the PAINAD tool as the pain assessment tool of choice in patients with dementia. Goals of this pilot project include A, to educate the nurse practitioners on the use of PAINAD as a standard pain assessment tool for patients with dementia. B, to evaluate the use of PAINAD in post-implementation in October, November, December, January, February, and March with these patients. C, to evaluate the nurse practitioner's satisfaction with the use of the PAINAD tool. Method. This is a Doctor of Nursing Practice pilot project implemented an educational session including a flow chart to encourage the use of PAINAD as the pain assessment method of choice in patients with dementia. Evaluation documents the use of PAINAD post-intervention in patients with dementia and surveys nurse practitioners to determine their satisfaction with PAINAD post-intervention. Sample and setting. This project includes convenient sample of 3 assigned nurse practitioners from this Medicare Advantage program, convenient sample of patients with diagnosis of dementia who were actively seen by the participating nurse practitioners in the months of August, September for inter-rater reliability, October, November, December, January, February, and March for evaluation of the use of PAINAD. This Medicare Advantage organization is located in Southern California. This Medicare Advantage organization in Southern California is a profit organization which employing about 65 nurse practitioners in 6 different locations. Intervention. Definition of PAINAD. PAINAD stands for Pain Assessment for Advanced Dementia. PAINAD consists of 5 behavioral items, which includes facial expression, consolability, body movement, negative vocalization, and breathing. Here's the PAINAD tool. You haven't seen it before. Okay. The PAINAD score is based on a 10-point scale, just like the numeric pain scale. A score of 1 to 3 indicates mild pain. However, in literature, supports that a PAINAD score of 2 or higher indicates probable pain, therefore pain treatment is highly recommended. A score of 4 to 7 indicates moderate pain, and a score of 8 to 10 indicates severe pain. Overview of the PAINAD innovation. A nurse practitioner will use PAINAD to assess pain in patients who have dementia as defined by the medical record and assessment of the patient at the visit at the following times: upon initial assessment and upon annual reassessment. When pain is identified, the nurse practitioner will provide appropriate pain treatment. Outcome measures. Nurse practitioners' participation in educational sessions, use of the PAINAD tool in assessing pain in patients with dementia post-implementation, inter-rater reliability for nurse practitioners and project directors on the use of PAINAD, nurse practitioners' satisfaction with the use of PAINAD tool. Timeline of the project. Education was provided to the nurse practitioners in August. The flow chart was sent to the 3 nurse practitioners in August. Inter-rater reliability during September involved joint visits with the 3 nurse practitioners to assess patients with the PAINAD tool. Post-implementation, data was collected in the months of October, November, December, January, February, and March by EMR review or electromedical record review to determine the use of PAINAD by nurse practitioners on appropriate patients with a diagnosis of dementia. Implementation. Meetings with the medical director of this organization to determine the support of the implementation of this project. Time for the educational session was agreed upon. Organization emails were sent by the project director to the 3 nurse practitioners informing them about the educational session. The project director distributed the educational PowerPoint slides and the flow chart to all nurse practitioners via organization email in August. Educational in-service. The first in-service for nurse practitioners involves a 1-hour-long education. The content included information on when to use the instrument, on which patients PAINAD should be used for, how to determine if a patient is appropriate for the use of PAINAD, how to score the behaviors, and when to document the pain assessment each visit, how to interpret the pain scores, where to document the pain score in the EMR, and how to evaluate treatment. In addition, information about specifics of patient documentation were discussed. Discussion on the use of the flow chart to reinforce the use of PAINAD and give guidance to nurse practitioners in decision making regarding pain treatment, intervention, evaluation, and documentation. Here's the PAINAD flow chart. Project director had a conference call on the 3rd Wednesday of the months of August, September, October, and November to problem solve with the nurse practitioner with the utilization of PAINAD and the NP's barriers on the use of PAINAD, and to reinforce the use of PAINAD. No data was collected with this conference call. Data collection. A clinical coordinator sent a list of the patients who are due for initial assessment or annual reassessment that were assigned to the 3 participating nurse practitioners. Project director reviewed charts and validated the patient's diagnosis of dementia in EMR and recorded the nurse practitioner's use of PAINAD on patients with dementia. Project director surveyed nurse practitioners regarding the use of PAINAD, educational sessions, and the flow chart. EMR chart review. In the process of EMR chart review, each patient was audited for the diagnosis of dementia in the assessment list in the patient's record for every initial assessment and for annual reassessment visits, and the dates of the visits and use of PAINAD by the nurse practitioner. Post-implementation PAINAD satisfaction survey. This survey was developed and reviewed by 2 experts, one in geriatrics and one in instrument development. The questions determined if the nurse practitioners had attended and in service and if it was useful, if it was helpful, if they found the PAINAD easy to use, useful, and would recommend it to their colleagues. If they found the PAINAD flowchart helpful, and if they would recommend it to their colleagues. They were also asked in open-ended fashion what barriers they had using the PAINAD and if they find the use of PAINAD helpful. Results, education. 3 participating nurse practitioners attended the 1-hour educational session. Joint visits. To determine inter-rater reliability, 3 nurse practitioners participated in the joint visit with the project director to assess patients' pain using PAINAD. The inter-rater reliability in scoring the PAINAD was alpha 0.96. Results of the PAINAD use, fidelity. So there were a total of 35 patients or observations with the diagnosis of dementia that should have used the PAINAD tool. So overall, there's about 83% on the usage of the PAINAD tool. Nurse practitioner survey results found the in-service helpful. So 3 of the nurse practitioners found the in-service helpful, easy to use, useful, and they would recommend the PAINAD to their colleagues. The nurse practitioners find the PAINAD flowchart helpful, and they would recommend the flowchart to their colleagues. So these are this is open-ended question. What do you find helpful in using PAINAD? So the nurse practitioners find very easy to use, used for patients who cannot speak or who have nonverbal cues of pain. It can be completed in less than 5 minutes, and it can be measured successfully in dementia patients. The next open-ended questions: do you have barriers with using PAINAD? So here are the barriers to use PAINAD in the 3 nurse practitioners' response. One is forget to use it. Some patients, dementia patients who are in the early stage of dementia may still be able to voice and enumerate their pain or report their pain reliably. And some patients may exhibit indicators of pain that may not be included in the PAINAD scale, such as confusion, withdrawal. Discussion. Overall, the fidelity use of PAINAD was about 83%, which is good. Only in March there's no PAINAD used when it should be used. Inter-rater reliability is good. The 3 nurse practitioners found the in-service on PAINAD helpful. The 3 nurse practitioners find PAINAD easy to use, useful, and will recommend it to their colleagues. The 3 nurse practitioners find PAINAD flowchart helpful and will recommend it to their colleagues. The open-ended question about what the nurse practitioner found helpful using PAINAD, easy to use, complete in less than 5 minutes, detect nonverbal pain behavior, and in patients with dementia, which are consistent with the literature. Open-ended question about barriers in using PAINAD, forget to use PAINAD. Some dementia patients are still able to voice or enumerate their pain, and some nonverbal pain indicators may not be included in the pain scale, which includes confusion and withdrawal. Limitations of this pilot project. It is a pilot project. It only involves 3 nurse practitioners. It only includes 35 patients. Conclusion and recommendations. The opinions of nurse practitioners about the use of PAINAD are consistent with literature. Recommendations. 1. Education sessions on PAINAD is recommended as a prerequisite for the use for the nurse practitioners. 2. In the EMR, at the face sheet or at the top of the screen of each document, dementia should be highlighted to remind the nurse practitioners to use the PAINAD for this patient population. 3. In the EMR vital signs section, PAINAD dementia can be added as one of the pain assessment tools to remind the nurse practitioners to use PAINAD for patients with a diagnosis of dementia. 4. Ongoing quality improvement and monitoring and reinforcement on the use of PAINAD for this targeted patient population. One is chart auditing as a strategy to provide feedback to nurse practitioners to use as a reinforcement on the use of PAINAD. 2. Supervisory visits with the nurse practitioners to reinforce the use of PAINAD and also make sure that they use the PAINAD tool correctly. 3. Nurse practitioners meetings, discussions, and feedback on the use of PAINAD will again reinforce the use of PAINAD. 5. Barriers in using PAINAD. 1. Patients have the capacity to enumerate the pain, so observe and listen to the patient. 2. Confuse, treat the confusion. There might be other causes of confusion, like it could be physical or psychosocial or cognitive as well. And 3, withdrawn patients, observe the patient. So withdrawal may be a sign of fearfulness or anxiety, or there could be other cause. It may be from pain as well. So I have developed a 3 vignette. Those 3 vignette case studies came from the dementia patient population that we collected data on from those 3 nurse practitioners. So vignette 1, CF. So this requires some participation from everyone as I go along with the cases. CF, an 81-year-old male with dementia, chronic diabetic ulcers, protein, calorie malnutrition, and end-stage CHF with continuous oxygen per nasal cannula. PAINAD score of 3, only with wound care, no documented pain treatment in progress notes. What's the plan of action, or what would you recommend for this patient? Anybody from the audience? Comments?
You said with greater than 2, didn't you, that
Correct.
the patient ought to be treated?
Right, correct.
PRN medication for wound care?
PRN, okay. So yeah, a PRN, pre-medicate analgesic, about 45 to an hour before the wound treatment. That would be helpful, right? Next. Vignette 2, EB, a 95-year-old female with diagnosis of advanced dementia, history of right hip fracture, AFib, anxiety, and depression. She was awake and disoriented, yelling constantly, and unable to carry a conversation because of her cognitive impairment. PAINAD score 5 on hydrocodone, 325 mg, 1 tablet every 6 hours as needed. Any comments from the audience? Recommendations for this patient?
Maybe she needs like routine pain med.
Someone says routine pain medication, okay.
Or intensive intensive training of the decision maker for PRN medication to retrain them on how to evaluate for pain.
Okay. So intensive evaluation, training on the decision maker to decide how to treat, identify the pain behavior, okay. So yeah, routine versus PRN medication, right?
Mm.
So if she's constantly yelling, probably has ongoing pain issues, right? So routine pain medication is appropriate. But however, there may times that may need to have PRN, breakthrough pain medication as well. So maybe to help the decision maker to identify when to medicate the patient, this patient for pain, maybe like hydrocodone, 325 mg, 1 tablet every 6 hour PRN when the patient's yelling, right? And any comments or anything? All right, very good. Last vignette, vignette 3, HD, an 89-year-old female with diagnosis of dementia, COPD, chronic pain. She denied pain when you asked her. Currently on fentanyl patch, 12 microgram per hour transdermal patch, change every 2 hours, and the PAINAD score is 4. How will you treat this person? Any comments or recommendations?
Sounds like her pain is well managed, but her score is 4.
Mm-hmm.
So, other causes of those, you know,
Okay.
could it be like a false positive? Yeah.
Should have a routine dose. Should have a routine dose or adjust
Mm-hmm.
the patch.
Okay. So we have comments like have routine dose adjusted for the pain level. Okay. Right, and the PAINAD score is 4. So basically, the pain, as earlier stated, that a PAINAD score of 2 or higher in the case of the patient is having pain. So probably the fentanyl patch that she's getting or he's getting is not adequate. So probably he might need that increase the fentanyl patch, or other options is to add other adjuvant pain medication or analgesics. Anybody have any comments? Okay, I think I'll stop here with my presentation, and I'll leave the room right now. Is that okay?
No, Madeline, don't leave. Don't
Okay.
leave yet, all
Okay.
right? You were right on time with your presentation, and I enjoyed it tremendously. What we want to do now before you leave
Okay.
is to ask Dr. Hendricks, Dr. Turner, Dr. Fields, if he's here, as well as any members of your audience,
Okay.
what questions they have to you.
Okay.
So you need to stay and answer the question.
Oh, okay. So I'm sorry. Anybody have any questions in the audience?
Hey, Madeline. Oh, go ahead. Go ahead. Go ahead, Dr. Fields.
Hey, George Fields here. Do you feel like you changed the way you practice medicine, Madeline, based on this study and what you learned from it?
Yes, tremendously. Based on the use of this tool, I have changed over the years, yes. Right now, I am much more sensitive to pain behavior, non-verbal pain behaviors than ever before. And I have, treated patients that many practitioners or clinicians have denied the patients of pain in such behaviors. Yes.
This is
What I love about this study, and just for the larger audience, one of the things the reason why we call it Care More Touch is because we actually touch the patient.
Yes.
And we teach and train our nurse practitioners not to rely just on lab and x-ray and data points, but to actually look at a patient as a whole person, body, mind, and spirit. And it's in doing that that you actually get to better clinical outcomes. And it incorporates that, looking and touching at a patient and seeing a patient and observing a patient. Do you think that this is translatable to the broader CareMore population of clinicians that are taking care of patients every day?
I would think very much so, because even though some of our patients does not have a diagnosis of dementia currently, but however, many of them already have cognitive impairment. I believe that this tool will be very useful in detecting pain with this patient population.
Yeah. Shameless plug, you guys. So sorry for this, but very proud of the fact that CareMore Health Plan received a 5-star rating for pain assessment, and in no small part due to what Madeline was doing and the way she carried it out to the rest of the organization. So kudos.
Okay.
Congratulations.
Okay.
We know in North Carolina it's not easy to get a 5-star rating. That's for sure.
Yep.
Okay, we have an audience here who would like to have a question. Go ahead, Joe.
This is Joseph Harrison. I'm a psychiatric nurse practitioner for CareMore. I actually share quite a few patients with Madeline. I was just going to say, to the point that Dr. Fields made, Madeline's philosophy of practice, which I think is well reflected in this presentation and the tool, it does actually shape a clinician's practice around her too. You know, it's definitely, she's very grounded in the fact that pain is often missed in patients who are unable to express it by normal means, and she teaches other clinicians that and reminds us of that, and it does change all of our practice.
Can you hear it?
Madeline, yes, we did. This is Christina Hendricks. Thank you for a very nice presentation, and actually very much enjoyed it, and you were very efficient, right on time, and which is hard to do when you're presenting. My question is sustainability of what you have done in moving forward. It seems to me that your training of 3 nurse practitioners has been a success, and I would like to hear your recommendation on how to move this project forward. I also noticed that the assessment was only done during the, admission, which is the initial assessment, and annually. So would you recommend this to be done in a more frequent basis? And the second question is, moving forward, do you think that nurses, in addition to nurse practitioners or even non-nursing staff, will be able to administer PAINAD so that, pain can be intervened upon promptly?
Yes, I think that you have many questions. I hope that I remember all of them. But for sustainability, I think I can transfer to the whole care more. I can give educations, and the 3 nurse practitioners who are already in the project, they can be the disseminator or the leaders in using this tool, and can help the regions to set up or implement on the use of this PAINAD tool in their region. And I'll definitely be supporting the rest of the regions as well, either through the call conference like here, or if they want me to be there present in the field to help nurse practitioners in using this PAINAD tool, I'll be happy to. As far as using this PAINAD tool for initial and annual, is because for the ease of data collection, yes, I would recommend to use the PAINAD tool as much as possible. Every visit is warranted for any patients who have cognitive impairment, communication difficulty, or even have diagnosis of dementia. And as far as transferring to the other clinicians and providers, PAINAD is a very user-friendly tool, so I think everybody can be learned easily. However, I think the only barriers that I can think of is that there's some resistance in using pain medication more than try to use the tool, because that's what I have been dealing with as I was trying to work with other clinician or collaborating with other clinicians. I hope I answered all your questions.
Yes, you did. Thank you very much.
Thank you.
As you're mentioning, the pendulum swings, and we're on the side of the pendulum where under medication happens all too often. Good insight, Madeline.
Thank you.
Madeline, this is Barbara Turner.
Dr. Turner, hi.
Looking back over that was a nice presentation. I enjoyed listening to it. Looking back over the project, is there anything you would have done differently?
Maybe may need more nurse practitioner, because 3 nurse practitioner for me is easier to handle, but I think a larger population would be even better. And I think that evaluating beyond the initial and annual reassessment on all the visits with the use of PAINAD tool will be much better. And also evaluating not just only the PAINAD tool, but on the response, on the scores, how the intervention is done based on the PAINAD score. That would be very interesting to find out. So those are the things that we want to add, but it's going to be more complicated if I add more of those factors, though.
That's perfect. Thank you, Madeline. By the way, I'm sorry, go ahead. Quick question, Mary, because I was reviewing the slides. Quick question again as far as the PAINAD moving forward. I noticed that in your review of the literature, you said that it should take about 5 minutes to teach people on how to use PAINAD. And I noticed that you took an hour to train the nurse practitioners. And as you know, clinicians are so busy. So do you think that this training can be reduced in time and still, achieve the same expertise that you achieved in your pilot project?
The reason that it's an hour long educational session is because it's more than just a PAINAD, because explaining why PAINAD is used, and also get the literature to support, to convince the user that this is the ideal tool to use. And not only that, but we talk about also some of the other non-pain behaviors that is not listed or scored in the PAINAD tool. So therefore it takes a little long time. But just using the PAINAD alone by teaching someone at bedside, it doesn't take that long. Probably 5 minutes, that's all you need. I hope I answered your question.
Thank you.
Okay, there's another question in the audience. Go ahead.
Hi, this is Robert Drake, clinical chaplain. I'm thinking of a recent hospice patient, 83 years old, I think, pancreatic cancer and dementia. And the huge problem was that there was no objective way to assess the patient's pain for the family. So it was entirely subjective based upon the pressure of the patient squeezed to the family member's hand. And the patient was highly under pain medicated. Could this have been taught? Could this be taught? Does it have application for family, for instance, in this type of situation?
That's a very quick question. I hope you all hear it. The question is that you asked about a patient, hospice patient who has pain that is under pressure. However, there's no tool for the family to measure the pain objectively, and that we tell the family about that there is pain exists, but however the family may be very cynical about it. Is that what you're trying to say? So yes, this PAINAD tool is not just for the clinicians, but however it should be requires skilled observation. But the nurse practitioners or clinicians can translate these behaviors and teach the families, non-medical professionals, on how to observe behavior, such as telling them that any behavior, like aggressive behavior that people know about, what it means, yelling, the crying, the resistive to care, what else? Even some patients who are withdrawn with sleep disturbance, poor appetite, all those behaviors can mean something. I mean, it may not be necessarily just mean pain, but it could be other things. But however, what's important is that to notify and alert the clinician to evaluate these patients, then the clinician can make a judgment of what the problem is and what to do about it. I hope I answered your question. Okay. Any questions or anything else?
And Madeline, the only thing that kind of struck me, and I think your response to it was correct, and that is one of the nurse practitioners in talking about what was the barrier was the notion that there's a spectrum of dementia. It typically progressively gets worse at a rate we can't always judge. But some patients, the diagnosis of dementia may not have advanced dementia. And the chart probably may not tell you that.
Right.
So I just want to double check your kind of response. And I think that would be an important thing to teach nurse practitioners or nurses or healthcare aides or whatever. But the notion would be if they have a diagnosis of dementia, then but they seem to be able to verbalize their pain. You listen, but you also do the PAINAD and look at the congruence between the two. And was that your recommendation?
Yes. So if the patient is still able, in a mild cognitive impairment, let's say patients still able to verbalize their pain reliably, so therefore we need to listen to their verbal as well as observe their nonverbal behavior. So with the literature study supports that the PAINAD score and the pain behavior should be highly correlated. So those two shouldn't be that much of discrepancy. But however, if there is, let's say if the patients verbalize a pain level of 7 and that your PAINAD scores comes out to be 5, so you listen to what the patient says. If you think that the patient is reliable in her self-report of pain, so you treat the patient accordingly to that verbal report of the pain. I hope I answered that question.
Are there any more questions from anyone? Well, if not, I would like to thank all who attended the presentation very, very much for coming. And now what we do, since this is a project event, only the committee members meet. And so we ask those in the audience, as well as Madeline, to leave.
Okay, we'll leave the room right now.
All right.
Do you mind?
We've had some projects, and everyone was unanimous in recognizing that you have met all of the criteria. So congratulations.
Thank you. Thank you for all your support.
So the next step, Madeline, is for you to work on the article for geriatric nursing.
Yes, I've been working on that, yes.
And the next month, and then all is well and all will be done.
Yes,
Okay?
I will.
Anyone else have any comments?
Anybody have any comments? Who's it?
Did you hear what Turner said?
No, can you please speak again, Dr. Turner?
I'm sorry, I said I think you ought to go out and celebrate.
Okay, thank you. Thank you.
Well, I think our work is done. Dr. Fields, Madeline will send you a form where you have to sign your name. And that is all you have to do with it. But again, it's been delightful talking to you across the country. And I want to thank everyone very much. And Madeline, congratulations.
Thank you, Dr. Champagne, Dr. Turner, Dr. Hendricks, and George.
All right.
Okay, you all have a great day. Okay, thank you. You all have a great day. Okay, bye-bye.
You too. Bye.
Okay, bye-bye.